Welcome everyone to our Set Your Sights Vision Rehabilitation Facebook Live Q&A. My name is Ed Plumacher. I am the Adaptive Technology Specialist at Lighthouse Guild, and I will be monitoring today's discussion. To celebrate Low Vision Awareness Month, the National Eye Institute, the American Optometric Association, and Lighthouse Guild have joined forces for this event. It is designed to spread the word about vision rehabilitation, tools, resources, and technology for people with low vision and for clinicians that work with it. We hope that today's discussion will motivate people with low vision to play a more active role in their eye care and to connect clinicians with resources to improve low vision treatments. Before we get started, I would like to have our panelists introduce themselves. I will start from my right here with Dr. Dale Larvik. Doctor, could you tell us a little bit about yourself?
Yes, I'm Dale Larvik. I'm an optometrist who practices in Lakewood, Colorado with emphasis in primary care and also in low vision issues. I sit on the Vision Rehab Committee of the American Optometric Association, and it's a pleasure to be here with you and share our information, and hopefully it comes out to be a benefit to you in your low vision needs.
Jen, could you tell us a little bit about yourself?
Hi, I'm Jen Novak. I am social media manager at Lighthouse Guild, and I lost my vision 2 years ago due to a condition called idiopathic intracranial hypertension, or IIH. Essentially, it's a buildup of spinal fluid on the brain, and I was asymptomatic, and the pressure from the fluid damaged my optic nerves, and I have low vision, and I have undergone low vision therapy, and I'm a strong advocate for vision rehab.
Great. Dr. Marc Wilkinson, could you tell us a little bit about yourself, doctor?
Yes, Marc Wilkinson. I'm an optometrist and professor at the Department of Ophthalmology at the University of Iowa, where I run the Low Vision Clinic. I'm also chair of the Low Vision Subcommittee of the National Eye Health Education Program, one of the groups sponsoring this event today.
Great, thank you. We're excited to have all of you with us today. As a reminder, I'd like to state that we are accepting questions from our audience. If you would like to participate, please submit your question and post it in the comments section for an opportunity to have it read during our live event. So let's get started. I'd like to pose our first question to the doctors. That question is, what is low vision? Doctor?
Okay, low vision is a very complex issue and covers multiple things. I'll address portions of it and then ask Dr. Wilkinson to comment as well. Traditionally, low vision is based upon measurements of visual acuity as well as field of vision and how it impacts how we function visually in our visual world. Traditional definition is visual acuity of less than 20/40 and with a visual field defect of less than 20 degrees, but that's not all of the definition. When we talk about visual acuity, we're looking at things more than acuity measurements, because that's just a hard number. It doesn't tell us about how our patients function. We're looking at a quantitative measurement in terms of 20/40. All that means is what you're capable of seeing at a given instant, a given moment in time. And it can be based on a single letter acuity, multiple letter acuity, single line acuity. It doesn't talk about the quality of vision that we experience. So just because your visual acuity is at a certain level, it tells us nothing about how you function in the real world. And that's what we have to really consider when we're looking at low vision issues, because there's multiple factors that are included. It's a very complex system, and we'll be talking about some of those today. So I'd like to have Dr. Wilkinson discuss that further.
Yeah, so one of the big things that changed with the NAI a number of years ago was to get away from the number consideration for whether somebody's visually impaired or not. And so the NAI's definition now is reduced vision not correctable by standard glasses, contact lenses, medicine, or surgery that interferes with the person's functional abilities, as you were talking about. So it's not about the number as much as just functional limitations. And if you have functional limitations that can't be corrected medically or surgically, with glasses or contact lenses, then you should be referred for a low vision evaluation so that you can see what resources are available to help you function at your highest potential.
Right. I heard the two of you say the same thing. It's all about functional vision, and that's why people are tuning in today, because they're dealing with low vision in their daily lives. So, to take this a little further, though, I'd also like you two doctors to complement what you've just told us and just expand the conversation to tell us exactly what is vision rehabilitation. Dr. Dell?
Vision rehabilitation, in my opinion, when I look at patients who we see with vision loss, regardless of the cause of it, whether it's congenital or whether it's acquired through disease or through trauma, it deals with enhancing and improving function. And we have to look at it from that perspective, what we can do to improve the way one functions, whether it's at work, whether it's in the school environment, whether it's with activities of daily living. Vision loss and low vision is a life-altering experience. And too often we don't look at those things in the process of vision and low vision. So vision rehabilitation is teaching a patient, training a patient how to use their vision and to enhance it so they can function out there in the world and maintain a life which is going to be good quality for them and good quality of vision. Mark, would you feel anything different on that?
I just echo that. So really looking at what the person wants to be able to do and how do we help them continue to accomplish those goals and strategies that improves their quality of life, which is really the key. It helps them to remain more independent. Not everything can be fixed, but we can certainly enhance function and learn alternate ways to do things. Sometimes we have to learn to use our ears more than our eyes for being able to do things, but there's lots of tools and strategies that are available for the individual specific needs.
Right.
In looking how the visual system works, I think it's important, as Mark just commented about other sensory information that we use. Vision is kind of integrated with other sensory systems, being hearing, being touch. All those things are important that we consider in the process of looking to design a rehabilitative program. But also it's important for us to understand what their needs are and how we can improve their needs and improve, again, the quality of life. So it's patient-centered. It's not a cookbook approach. It's a patient-centered process, and it's a continuum of care. The continuum of care involves, in my opinion, continuing to work with issues that a low vision patient has throughout their life, because the course of disease loss can change, but also at times there's many more things that can be done. In the process of rehabilitation, a lot of it has to deal with therapy or teaching them how to use devices or how to use their existing vision. So it's not as simple as prescribing a simple low vision device or an aid. That's helpful to some extent, but as we learn to interact with the patient, we find out how they process information or how they don't process it and what we can do to help them. And this covers the whole gamut of age groups, from the aged population and also to the younger population. Restoring quality of life, but also giving them a future so they can go on and have a career path, be self-sufficient, and be able to function independently.
Great. You have anything to add to that, Doctor?
No, that's good.
Okay. Yeah, so, the next question was basically, who needs low vision? I think we've addressed most of that, but what I gathered from both of your answers is that a lot of it has to do with the conversation that takes place with the individual patient. So when you have someone that you identify that specifically needs low vision, how do you deal with the resistance that you may get from that?
I think that one of the big things to recognize is that people with vision loss are dealing with a loss. And there's many different stages that you go through whenever you experience a loss. And if somebody's stuck in anger, depression, we need to work with them to get through that, to be able to be at an acceptance level, to start using the devices and tools that are necessary to help them function better. And I typically will tell patients, my job's to show you what tools and strategies will help you. Your job is to decide what help you want. And if you're not ready for that help, it's okay. We like to have a family member there, sort of a team coach, if you will, and have that person listen to the things that can help that person and maybe be the one who helps them learn to make those adjustments. But we're not going away. We're here to help. And so I think it's when that person is ready for that help, ready to accept their situation, and that may require some counseling or some group therapy to get to that point.
I agree. There's multiple things that are involved with rehabilitating any kind of a loss, in this case loss of vision. And the patient needs to be ready to be able to step forward, because if they're not, there's nothing we can do to help them through that. So that's where the counseling comes in important. But also, I find that patients come in sometimes with a preconceived notion that nothing can be done. And they're here to see us because somebody else suggests they find a way to help themselves. And so they come in sometimes thinking nothing can be done because they have sometimes been told that. And so part of the process is helping them understand that there are things that can be done, but there are also some things we cannot do. And oftentimes we see patients who come in who have what's been referred to by others as a yes but syndrome. And so when we find out we can help them, they say, yes, I can do that, but I'll have to hold things closer, but I cannot do it like I used to. And so we have to work with them through the process of going through the stages of helping them understand what they can do, what they can't do, or we can help them with. And that's a process. And it takes time, it takes acceptance, and they need support groups around them. Having family that understands the nature of their vision loss, I think, is very important. If a patient comes in with nobody else with them, it tells me that sometimes they're on their own. We have to approach it differently. If they come in with family, it's important for the family to understand the nature of the vision loss and how it affects them in everything they do. And that's a process to go through, because if we have family that understands it, they can relate more to providing the support that they need.
So it's interesting that one of the primary things we start with is, do they have the right glasses prescription? And believe it or not, people forget about that. If you have some retina problem going on or something, then they may forget about the glasses thing. And I'll say to patients, well, I think we need to check and make sure you have the best glasses. And they'll go, oh, so-and-so told me that wouldn't help me. And I said, but did they try? And they go, well, no, they just said it wouldn't help. And I said, well, let's just try. And many, many times you can just, with glasses, improve the function of distance or reading vision for patients. And so that's always our starting point. That's an important starting point before we start looking at other tools and devices.
Right. Sometimes we're so focused on the harsher aspects of it, we forget the low-hanging fruit.
Yes.
Yeah. So, a lot of it has to do with independence, but I think it's key is when people are dealing with their own personal low vision, I mean, they have to have the autonomy. It's their decision. How independent do they want to be, and what type of services do they want?
Yes.
So, Jen, I haven't forgotten about you, so I do have a question I'd like to pose to you. So, where do people with low vision seek out and find vision rehabilitation services?
I always say start with your eye care professional. No matter where you are, they know the region, they know the locality, they know the organizations that exist within that region. It's always best to start there. And then also, your local organization that serves the blind and low vision community is a tremendous resource as well. They often know the resources that are available in the area as well, and can sort of set you on the path. Also, at lighthouseguild.org, we have a directory that is, literally a nationwide resource that, can serve as a starting point as well. So it's just important to remember to take that in your own hands and to actively seek out your services. But, definitely start with your eye care professional and to get that process moving.
Right, and that's the key. There's no cookie cutter solution, because everybody lives in different states. They have different regulations and different services available to them. So starting with the eye care provider is definitely the best way to go.
Absolutely.
Yeah, good.
I would say that another thing, and Jen, thanks for presenting it that way, because you have to be an advocate for yourself. And some people have difficulty being an advocate for themselves for a variety of reasons. But there are other resources. If you find you don't get the answer from your eye care professional, don't stop at that and think nothing can be done. Because too often we will see patients who've been told nothing can be done, and probably from a medical treatment standpoint, therapeutic, surgical point of view, nothing can be done. But from a functional point of view, from a rehabilitation point of view, there's lots that can be done and can be achieved. So state associations of the eye care profession sometimes have low vision committees, which also be a resource, or dealing with services for the visually impaired or vocational rehabilitation departments can probably send you to somebody within the community, if you have that kind of a community you live in, to get the help or guidance or referral to somebody who can get you along the right path.
Absolutely.
Let's not forget the aspect of social media too. I mean, there are scores of blind, visually impaired support groups on Facebook alone, and you can gather all kinds of information about your particular eye condition or about your particular state services and things like that. So, social media on Facebook is a great place to go.
I think it's a good, to talk about social media, but sometimes people go to the wrong spot. And so you do have to be a little bit cautious about the things that you go to. And I've had patients when now it's so easy, you just say, oh, what website were you looking at? Let's look at that together, because sometimes they're looking at a symptom instead of a diagnosis. And it can be very confusing because there are people who have a story to tell that maybe isn't appropriate for what that person is going through. But there are lots and lots of resources. The National Eye Health Education Program has a great resource within the NEI website. Just looking at low vision. So there's lots of resources. There's a great video that gives testimonials of patients who have overcome their vision problems. And so take advantage of looking at those social media venues for getting more information.
Great. Excellent. Anybody else have anything to add to that, or are we good?
No, I'm fine with
Good,
that.
good. Do we have any questions from our audience?
Yes, we do. We have some questions, and audience participation is very well welcomed. Maria has asked a question: what was the most helpful thing for Jen with low vision rehab?
Hi Maria, thanks for tuning in, first of all. I would actually say learning to use the white cane was the most important part of vision rehab for me. Initially, I got the cane as a marker. My best friend had suggested to me, we were on a crowded New York City street, and I couldn't find him in the crowd, and he made the suggestion that I should probably think about it as a way to let other people know. And as I launched into my therapy and learning how to use the white cane, it became an instrumental navigational tool for me. With my vision, I see mostly gray, and so steps look like a slope to me. I couldn't navigate the stairs without the cane. Just walking down the street, cracks in the pavement, changes in the pavement, changes from pavement to grass. It has just really improved my life and increased my independence.
Yeah, I agree with you because of the things. I'm also have low vision, and proper cane training was my source of independence. It gave me the ability to jump on the train and go into Manhattan. It allowed me to volunteer in positions to regain my business skill sets, and which led to full-time employment. Right. So but the key is proper training. Just grabbing a cane and going out there.
That. Yeah. You really need to work with a mobility and orientation therapist to learn the tricks of the trade with the cane and really how it functions and how to use it. So that's very important.
Okay, great. Before we take another question from the audience, I would like to address one more question that we had that you started to speak about, which was dealt with advocacy. So I'm going to address this question to Dr. Marc Wilkinson. So, how does someone with low vision, doctor, advocate for themselves for low vision rehabilitation services?
That's a great question. I mean, it sometimes can be difficult because their eye care provider may not really be thinking about that. Too often they're thinking about, is there something medical or surgical I can do to restore vision? And so you do have to be an advocate. I think having family members help you to be an advocate, ask questions, social media, ask other people, ask patients, friends who are visually impaired. It's amazing to me the diversity of people that I see who have met other ones of my patients where you think, well, there's no way those two people would have ever gotten together. But I think you start with your local eye care provider. You say, where can I be referred? What help can I get? And then you take advantage of state associations, support groups that are around. Other people are going through what you've gone through, and you just have to be tenacious to try and find the help that you need.
Yeah, and that's the key, that you have to be tenacious. Too many people, they get discouraged because they haven't heard back right away. So you have to be tenacious in your approach. Squeaky wheel gets the oil. And the thing is to manage your expectations. It does take time. You are dealing with government agencies, and there is some bureaucracy involved.
I'd like to go back to the comment about the white cane, because I think this is an important thing. And I would say to the audience, if you look at Jen and Ed, you would not say that they look like people who are visually impaired or low vision. And the reason for that is that we have in our mind's eye the image of somebody who's got a vision problem. And that person is somebody who's probably been blind since birth, and you can usually spot them from a ways away. And so you two know that you don't look like that stereotype. And so people will look at you and say, what do you mean? What are you doing? And so the beauty of having a cane is it's a mobility aid, it's an identification tool. And if you happen to bump into somebody, or somebody bumps into you, they're going to get out of your way with the white cane. And I think the white cane is helpful. I even have patients who will pull it out when they've driven into a parking ramp, but the parking ramp is dark, they have trouble in low light, and they'll pull their cane out to get it safely out of the parking ramp. So it's not something that's just for people with severe vision loss. It's a helpful tool for lots and lots of people with vision problems.
Absolutely, absolutely. And I still have usable vision, but I rely on my white cane.
Those are good points, because I think often, especially when we see low vision patients, two things come up. The one is us being able to understand how functional capacity has been affected with the patients, but also encourage them to share with us the difficulties they're having, and not just assuming that this examination or evaluation is going to take care of those things. Unless we engage patients in a discussion to find out where their problems are, we're not going to probably know how to address all those issues. And talking about mobility concerns, say, in different lighting environments. Enhancement of light, enhancement of issues with contrast and glare is a significant part of dealing with rehabilitation, because you can find somebody in a well-lighted area who functions very well, or somebody who sits in a room where you have backlighting come in, just creates all sorts of glare, they can't function very well. Or like in a dark environment, if you have issues with mobility. So those are all things, and it's not just one little thing that's going to help the patient.
Right.
Multiple things occur, and that's why the comprehensive type evaluation should be involving all those things. One of the things that I tell patients we start to talk with them, and this relates also to getting to know the patient better, is I say, we're going to look at ways, first of all, to identify your level of vision, but more importantly, we're going to concentrate on ways to enhance it, to improve it, to improve your functioning. And once they hear that, they say, oh, good, because they come in just initially thinking, well, I'm just going to get a pair of glasses, that's going to solve the problem. Because they don't understand what the disease process is or what's happened to them has affected their vision. It's extremely complex. So in part, we're educating the patients, educating them on why this has occurred, how it's affecting what they've had, but how we can improve it. And then the time course involved from us going from evaluation to therapy to being out in the real world and looking at a career path for them to take, which is reasonable and obtainable.
Yeah, and the thing I see too is that, a lot of students that I have is that there is a resistance to initially pick up that cane for the first time, and it's a shame that most of them don't do it until they've had some kind of fall that gave them a severe injury.
Yeah.
And that's unfortunate. So I encourage all my students to use the cane whenever they can. So I know we have some good audience participation. So I believe we have another question, Doctor.
Yes, we do. And Donna has asked, what is the best time of the day for people to participate in vision rehab? So, Marc, I'll let you address that first.
I think, starting out, it would be just any time of day. I don't know that there's a specific time that would be better than others, but I do think if you have problems in low light, then you would want to be with a mobility instructor and doing some night travel. I always say, don't take me to a familiar place. Don't take this person to a familiar place that's well lit during the day. If they have trouble in low light and unfamiliar settings, that's where they need to be assessed and trained. Right. And so that really just, it depends on the function. But for, a clinical low vision evaluation, we'd see them anytime. So if there's, anytime they're having trouble, but then the very specific things would be for those times of day where they have more specific problems.
And it's situational too. If you work in low lighting, your mobility therapist is going to take you into that sort of situation, immerse you in it, and make sure that you're comfortable there. I remember I had problems with the stairs, and we went to the local mall, and we did the stairs over and over and over again. And we also did the escalators while I was there. So it was great. I could experience all of that, and I could sort of wrap my brain around the steps again. So.
And the thing is, what you need to do is step out of your comfort zone as well. It's not easy. It's hard work. It's a lot of training, and the things you need to do, you need to deal with those situations because yes, you might be able to just go from point A to point B most of the time in daylight, but you may find yourself in an emergency situation. So you should know how to deal with that low light or nighttime situations.
The other thing I'd like to add is that vision itself is an extremely dynamic process. For those of us who are blessed with good vision, normal vision, we don't understand how things work totally. As long as we can see, or if we don't see, put a pair of glasses on, all of a sudden we can function. But the processing that occurs is extremely sophisticated and quite complex. Then you throw in a situation dealing with low light issues, it's even more so. So the dynamic aspect of it and training, which you had mentioned, Ed, is extremely important. And I also tell patients when we're doing any kind of a therapeutic approach, I said, there's going to be some times when you're very frustrated. There'll be some times when, you're very angry, and that's normal. You're dealing with lots of issues, and we're dealing with the vision component, but many of those things you have to have the support around you. And that goes back into what, Mark, you mentioned as far as counseling. At some point is involved in all those aspects, and just to be able to take care of the person, not just a pair of eyes. So,
good. Earlier you had mentioned dealing with low vision and how it's life changing, and we all know that people with low vision, it can be financially devastating in addition to being emotionally devastating. Many people who lose their vision or have struggle with vision end up losing their jobs. So their livelihoods are affected and their financial situations are affected. So, Dr. Dale, I would like to ask you, how is somebody with low vision, how do they pay for vision rehabilitation?
Well, if you look at the components of visual rehabilitation, there's the clinical aspect of the evaluation. In many cases, these services are covered under regular insurance if you have insurance itself. So that's the first component that needs to be taken care of. And medical insurance will cover most of those tests from a clinical point of view. Some will not be covered, but a majority would be. So not to go seek out low vision care because of not thinking you'll be able to justify the cost is one thing. If you don't have insurance, there are state agencies which can provide some financial support to it as well. The other component is dealing with the low vision devices. Technology is always evolving, and there's new technology coming out all the time. Some of it's very sophisticated and is more than what a patient needs. My approach is to go with the simplest device possible to allow them to enhance and maximize their level of vision. And lots of times it does not really involve all that much to allow them to be functional. Those types of services are not covered by many insurance plans. Low vision devices are covered by some vision care plans which have a low vision component. So I think the first thing to do is you check out, if you do have insurance, to check out your insurance plan to see what services are covered, because sometimes there may be separate bundled plans which can be covered through that.
Right. Both you doctors work from different states, and we all know that each state has their own regulations, their own services that are available. So, Dr. Mark, do you have anything you could add to that?
I would just add that depending on the age of the person. So if you're a school-age person, then you're going to be covered under IDEA, the Individuals with Disabilities Education Act, if you need an IEP for devices. If you're working age, then your state association for VOC Rehab or your blind association should help you with devices and tools to get you in the workplace. Because obviously you're going to do better if you're working, and you're going to be an asset to the state if you're working. The problem is older adults. If you're a veteran, then you have resources through the VA system, but beyond that, then it becomes a personal financial thing. If you're somebody with macular degeneration and you're 65 or 75 years old, you're not going to find resources that are going to pay for those devices. Unfortunately, sometimes we have to do fundraising. Sometimes there are things that are donated through Lions Clubs and other options like that, but it's not a perfect system as far as getting devices to the people who need them at this point.
Yes, that's unfortunate, but usually there's something out there. You just have to do your research, yes. I know we have another question from the audience.
Yes, we do. Shelley has asked the question is, what are some of the skills that a person would need if they're living alone? And I think that is a great question, Shelley. First of all, independence is at the forefront of that, because as you have vision loss and loss of independence, it's very devastating, especially as you get older. So I think there are lots of things that can be done, and Jen, do you have some ideas on that?
Well, I live alone actually, and it's also even though you live alone, it's good to have your network of people around you as well. I have a very strong support network and friends, and if I need something, I know I can rely on them to help me, whether it's trying to figure out a color of something, or I'll send pictures to my friends. I bought this. What color is it? Things like that. It might sound silly, but it's one little thing that has helped my life tremendously. And it's also just really getting to know your surroundings as well. Knowing where the stove is, what's in the refrigerator, knowing how things feel, different products. What does the milk feel like? What does that package from the deli feel like? And things like that. So, you are relying on your other senses as well. Again, this is where mobility and orientation come in. They will come and help you in your home and help you label the stove, help you label the refrigerator. I personally didn't need that, but many people do, and they will walk you through your house and make suggestions room by room. Lighting. There's so many levels to it, and there are places that will help you, starting with your mobility therapist, but also just your family and friends. They have really come through for me.
I think occupational therapy does that quite a bit too. They come into people's homes. I think one of the problems that people, particularly as we get a little bit older, are concerned about if they develop macular degeneration or something is that they'll have to move from their homes. And I always tell them, I have a number of blind friends, totally blind, who are living independently and continue to do that. You may choose as you get older that you don't want to do that, but there's no requirement that says that you have to leave. There are people who can come in and teach activities of daily living, teach you how to cook, how to manage things in your home, and you should not assume that you have to lose your independence because you have vision loss. And you two are good examples of people with vision loss who are independent, working members of society. We may choose to do things differently at different levels, but you don't have to do that.
And that's the key. You can learn how to do things differently. I know at the Lighthouse Guild, we have people that will go to your home and they'll teach you how to properly cut vegetables and prepare meals and things like that. Not just make simple meals, but to, make some of your favorite dishes you made before. Do it without injury. Do it without getting burned and without cutting your fingertips off. And those skill sets can be learned. And there are devices that they'll provide for you with high contrast cutting boards and things along those lines. So there's lots of things you can do with that. So
I think what's amazing with this too is that, and Mark mentioned this, that you have patients who have all levels of visual impairment to totally blind, and how they have learned to adapt, some on their own and some with certain help. But they function extremely well. And so from that we say, well, if they can function that well, why can't we train somebody who has certain types of vision loss, whether it's visual field or acuity, why can't we train them? And you can train them through therapy to be able to do those things. There's a certain amount of plasticity that occurs in the visual system. So we're dealing with very complex neurons in the visual pathways and integration in the brain in the visual cortex. There's a plasticity that is there, and it can be retrained and developed how to function to compensate for certain losses of sensory information.
I think one of the things that's interesting to think about is that everybody's different. And so to say that at this person at this level they can do X, Y, and Z because somebody else does, that's not necessarily true. And one of the examples I have are I take care of lots of people with vision problems who wish to drive or wish to continue driving. And some of them, and I always ask them, the first question is, do you feel safe? And if the answer is no, then it doesn't matter what their level of vision is. They shouldn't drive if they don't feel safe doing things. And sometimes their family are saying, oh, but you have to keep driving or you have to do this or that. So if they do feel they're still safe, then do they still qualify to drive? That's the next question that comes in there. But we can't assume that just because some other person is able to do things that you're necessarily going to be able to do it because you have the same quote-unquote condition.
And if I can just add, that's sort of the magic of vision rehab. It is individualized, and a plan is literally created based on your lifestyle. You know, you'll be asked a number of questions, you know, from work to home to transportation issues, and it's really a solid plan created for you to teach you the skills that you need to live that lifestyle and to be independent and to suggest the tools that you could use. Right. So that's really the wonder of vision rehab.
Mm-hmm. And usually you're working with, you know, a trained, educated professional who has a passion for what they do. They love positive outcomes, and they're there to help you with your individual needs. So what I'd like to do, Jen, I would like to address this next question to you. Mm-hmm. And you and I, we're colleagues, you know, we work together, and we've had conversations before about how I feel like your acclimation to blindness is probably, I would put it on the fast track. It's quicker than most people I've ever encountered. So I'm going to ask you, you know, how, as someone with low vision, have you adjusted to dealing with that?
I lost my sight 2 years ago in January 2017, and my initial thought wasn't, you know, that this was the end of my world as I knew it. It was, how am I going to function as I used to with full vision? And that's sort of what inspired me to launch my vision rehabilitation almost immediately. I had a 25-year career in public relations that I did not want to give up. I had every hobby I had involved my sight: going to the theater, traveling, going to museums, writing. Those were all important things to me, and you know, I immediately wanted to sort of discover and find those tools that could help me return to doing the things that I loved: my job, my writing, going to the theater. And you know, some things were easier than others. You know, magnification software for the computer, you know, that was a tremendous help because it brought me back to work. You know, and going to the theater, I know I keep saying this, but it was so important to me. And I remember going, you know, before I went through vision rehab, and the stage was just one complete blur to me. And, you know, after I saw my low vision specialist, he recommended, which I'm going to show later, a very simple pair of sporting glasses. And I remember going back to the theater after I had them, and you know, I could see the actors again. So it's little things like that that are important. Also, you know, my work. I actually, you know, had a bit of a change when I lost my sight. I wanted to give back with the usable sight that I had, and that's how I landed at Lighthouse Guild. You know, I wanted to really work in an environment that serviced, you know, the blind and low vision community. And you know, there's a lot of hope out there, and that's what I want others who might be in my situation to know.
Right. You know, we went along similar paths. You were a little more on the fast track than I was. You know, I worked in sports television production. I was CEO of my own high-tech firm for 20 years.
Right.
And I had the advantage at that point, as my vision was degrading with retinitis pigmentosa, if there was something I couldn't do, I would just hand off that task to one of my employees. When I stopped working, I realized now I'm sitting at home, I'm in retirement, and I don't know how to be blind. I didn't know where resources were. I didn't know what resources were available to me. I wish I had had a forum like this that I could have observed to maybe learn some of the things we're discussing here today. But it was going through that, you know, grief, anger, fear, and frustration that we spoke about earlier. You know, those things are real. they're emotional and they take their toll, and it takes time to get through that. It took me some time, when you work 24/7, 52 weeks a year, and all of a sudden you just come to a dead stop, and it's difficult. And I can only watch so much Judge Judy and and Love Connection on TV. That wasn't going to do it for me. So it was eventually just sheer boredom and frustration that drove me out, that forced me to grab that cane, which sat in a package in my closet for almost a year and a half because I refused to touch it. And going into Manhattan and meeting a college friend for the first time in a long time, and then realizing that this is what I need to do. So, those things are available, and you just need to take that first step sometimes.
Absolutely.
Those two perspectives are unique because it goes back to what Mark said about each individual case we see is different. And just because of where a patient is in their lives, what their needs are, and what we can do to help. And we can't always expect somebody to progress at the same level. Some take a much longer time to get there. Sometimes their expectations are not realistic. So we have one more question before we look at some of the aids you mentioned, Jen. And Greg has asked us, what are some tips for interacting with visually impaired people? I think probably that you'd be able to address that.
I think one of the biggest things you can do, and I have this happen to me every day, because I travel almost 2 hours in the morning and 2 hours at night after work to go, commuting. So I'm on the Long Island Railroad, and then I walk over and take the subway system up to the area where the Lighthouse Guild is, and then walk over. And every day, people in New York, they're always offering to help. Some of them do it graciously, and some are abrupt. There's a fear factor that steps in. They're more worried about me getting hurt, so they're not as concerned about how they'll approach me. So you'll get grabbed and you'll get manhandled sometime. And I don't subscribe to the philosophy that I need to chastise that individual. That person is looking out for me. That person is not educated on how to deal with me. The best thing you can do with somebody with low vision is walk up, offer assistance. Don't touch. If they say, yes, you can help me, then offer them an elbow. One of the things you'll do with somebody who is well trained with low vision, with mobility, if you help them, they may just lose their orientation a little bit. It only takes a few feet to be off on a subway platform, and you can end up on the tracks. So sometimes if I refuse help, it's not because I don't want assistance. It'd be nice to have it, but I know that I run the risk that I may not be exactly where I want to be when you let go of me. So it's better for me to use my skill set that I spent a lot of time developing and have had a lot of training, thanks to the sponsorship in New York Commission for the Blind, to deal with. So I work through that. So the best thing to do is offer assistance verbally. If they accept it, then offer an elbow. That's the best way to do it.
And also, I encourage the people in my life to ask questions. I enjoy that openness. If something, they'll ask, should I take your arm? What should I do? Do you need me to tell you where the curb is? And things like that. And now they've spent enough time with me with the cane and everything. They know that the cane will tell me. But initially, people had questions, and I welcomed that because they cared enough to inquire. What's best for you. So definitely ask questions. Ask questions.
I think looking up online a sighted guide, and I know the Lighthouse Guild has that. I have that at the University of Iowa on my website as well. Just know how to be a sighted guide. Know how to approach somebody and ask them. Don't pull, grab, or push them, particularly children, but anybody. But know how to act like a sighted guide if you want to help somebody, and it works great.
Yeah.
All right, let's take another question from our audience.
Okay, we've had a lot of questions, Ed, about technology, and we've talked about technology, and technology is great and wonderful. So why don't we talk a little bit about technology in the form of vision rehabilitation and the role it plays, and maybe, Jen, you could relate to that just because what you've experienced.
Technology is wonderful at this point for people who have low vision or who are blind. And it's growing every year, what's available. And it can be as low tech as a cane. I use handheld magnifiers, again, glasses. I don't know if do we want to show these?
Yes,
okay. This is very simple, but it's it's extraordinarily helpful. It helps me with my mail. It helps me see credit card numbers. It's just a lighted handheld magnifier, and you literally put it down over the text, and you can see it enlarged enough to read. We also,
Just to point out, the beauty of this is you don't have to hold it at a fixed distance. You set it right down on
Right.
what you're reading. And so for somebody who has hand tremors or some arm weakness, that's a really useful tool because they can just set it down on what they want to read.
right. I am also partially colorblind, and I can only see blue and yellow. And this is what's called the Colorino, and it will scan what you're wearing, or if you're in the store and looking at curtains and need to know if they're blue or pink, this will tell you. I don't know if you can hear it or not, but it's saying black, the color of my dress. So that's another tool that's quite useful, on a day-to-day basis.
And it helps go back to you being independent, living alone, so you don't have to worry about, what you're doing as much.
Absolutely, absolutely. These are actually the glasses that I mentioned earlier. I wear these at the theater, and they're just magnification glasses, and they actually help me see the stage much, much better. And they restored my love of theater for me.
So those are called spectacle-mounted telescopes.
Okay.
So you can have a telescope, a monocular telescope that you hold with one hand. Binoculars are another option. We have some binoculars there.
We do.
But these are spectacle-mounted so that you can actually put them on and wear them, and there are different strengths and different styles of those.
They are.
And can be very helpful for enhancing distance vision, just like binoculars do.
And these are just, a very simple pair of wide-angle binoculars. They're self-adjusting, and I use these to watch TV. It helps me be able to read the screen. And then, of course, we have the white cane. And Ed, I believe you have.
Yeah, I had brought a portable CCTV, which is a closed-circuit television system, which allows you to, when you turn it on, to just lay it on top of the document you want to read, and as you can adjust high contrast, whether you want white on black or continue with black on white. And there are other various color combinations depending on what your eye condition is. People with different eye conditions have different preferences for color backgrounds and fonts and styles and print. Magnification levels, so increase the magnification, lower the magnification. What I like about this particular unit is it also allows me to use it as a distance viewer. So if I hold it up like this, I can actually make out Dr. Marc Wilkinson across the table from me, which I can't do if I look at him directly. So, these are similar type of devices that we have. Dealing with technology all the time, one of the things we've talked a lot about magnification, but speech is very important. Especially if someone wants to regain work in the workforce and they're going to work in an integrated work environment. Because if you're going to compete in a workspace where you're dealing with sighted colleagues next to you, it's great to get the job, but you have to keep the job, which means you have to work at a pace which is competitive with the workload that they carry. That's only fair. You're being paid a fair wage. You're expected to put in a fair amount of work and output. You can accomplish that by integrating speech into your workflow. And we find a lot of resistance with this with younger students transitioning from high school to college and things like that, because they don't want to be different. They don't want to be in a dorm with their speech synthesizer going off, even though they could use headphones and things like that. But when you're ready to go to work, you need to step up and integrate that into your workflow. And not just do it at a conversational level, because if you're going to listen to a document read to you at conversation level, that's only around 160, 165 words a minute. The person in the cubicle sitting next to you is reading that same document at 330 words a minute. So they're already processing information at twice your rate. So you need to step that speech rate up. And that's just something that you're able to train your brain to do. Just notch it up a few percentage points a week, every 2 weeks, within a few months, you're listening at that 300 to 330 word per minute, and you don't even notice it at that point. The other thing is it also puts you into a stealth environment if you don't have any headphones, because the average layperson will hear your screen reader and not be able to decipher anything that's coming out of that device.
Ed, you said two things there which I think are important, and one being magnification.
Mm-hmm.
Well, magnification is not always the answer for many people.
Right.
Primarily for those who had central field loss, blind spot area, so to speak, which we call a scotoma. It means when they look at something like their brain has been wired to do all their life, they still look with that part of their vision. When they look with that, things disappear or they're gone or missing. It becomes very frustrating to them. So for magnification to work with some patients, we have to literally teach them how to view off-center. Mm-hmm. It's a process called eccentric viewing. And through a process of therapy, relearning, you can do that. Mm-hmm. So that's something to keep in mind when we look at magnification levels. Sometimes too much magnification is adversely proportional to what their gain is going to be. Mm-hmm. So that is critical. And the other thing, as you said, you can processing. Visual processing, if we have central vision, is one thing. If we're using our peripheral vision, we have to relearn how to visually process information. And so yes, it is slower. So at the same time, we have to be realistic. And when one does a comprehensive low vision assessment evaluation, mm-hmm. those who are trained will look at all those factors with, first of all, the level of measurable vision, how they function with the disease process, and then what's realistic for us to be able to help them to do things. Mm-hmm. If you jump in too fast to it, you're going to probably not be as successful. Mm-hmm. And then you're going to have this attitude or this problem to deal with, is saying, what can I do now? This didn't work for me.
Yes.
It may have been that they haven't tried hard enough or haven't been given the right tool or trained properly. And I think that's very important with rehabilitation.
So I want to go back to your video magnifier. I think that it's important for people to understand that what you mentioned, the contrast can make a huge difference.
Yes.
And there's so many people who read so much better with white letters on a black background. Mm-hmm. We have the other color options as well, but I think sometimes just switching to white on black, and you can do that on tablets, you can do that on e-readers, you can do that on smartphones, and people will oftentimes go, wow, that's the only thing I needed. I just didn't realize that switching the contrast could make such a difference, and really with very little magnification. So that's an important thing to know. And that's the problem with an optical magnifier, is it doesn't change contrast. So if you're looking at 70% contrast in the newspaper and you need 95, it doesn't matter how big you make it. If you don't make the contrast better, you're not going to be able to read it better.
And we see that a lot in our computer lab. Someone who comes in with retinitis pigmentosa like myself, the first transition you have is, like you said, sometimes just doing the black background with the white print is all you need to continue on for a little while, But somebody comes in with Stargardt's, that background or macular degeneration is going to remain white because they don't process as well with the black background. So glaucoma, a lot of times I see people like to have a blue background with yellow lettering. So it's all individualized. That's correct.
You got to try out the different options to see what works best for that person.
Right.
So.
Mm-hmm. Okay.
Mark had mentioned something about cell phones, and there was a question that was proposed by Ed in the audience who asked, are the benefits of a cell phone adequate or enough? So since you mentioned something about cell phone technology, maybe you can address that from the standpoint of technology and rehabilitation.
I think that a smartphone is somebody with vision problems' best friend, because you can do so many things with it auditorially. You can also use it as a video magnifier. You could actually put a free app on your phone that would make it work as a video magnifier for spot reading. You can put an app on that will read barcodes, that will read numbers, that will read text to you free of charge. So there's so many great apps that are being made for smartphones, and the ability to be able to communicate with self and others is really a big deal. I have a patient who's 14, and his mother said to me, well, his friends wonder why he does FaceTime because he's congenitally blind. But that's what his friends are doing. They can see him. He doesn't need to see them. He's doing what other students are doing, what his peer group is doing. And so I think that a smartphone, a tablet can be very, very useful tools, sort of out-of-the-box things that everyone's using, where you don't necessarily need to invest in these more expensive options, and you can do a lot of things these days with these relatively benign devices that are out there.
And that's the key, what you said, inexpensive. We're living in a time today where inclusive technology is being developed. Apple has developed the iPhone. VoiceOver, which is their inboard screen reader, and magnification level for Zoom is built in. It's the same phone that you would buy to use that I use. The only difference is I have activated the accessibility features of that phone, and it works well. And with a little training, I mean, there's only 20 finger gestures you really need to know to really adequately, do that phone, use it, do voicemail, deal with email, and deal with text messaging. I mean, those are the things, and then surfing the web as well. Right. The other thing you do with the phone is you can access Bard Mobile, which is a great app for the National Library Service. You can download all your audiobooks and have them with you at all times. It's you not have to lug around these extensive players and things like that. One of the apps we spoke about earlier today in a meeting is Seeing AI, SEEING space AI. It's developed by Microsoft, and it has tons of unique features. It has a short text mode where by activating that app and just aiming it at some text or even a computer screen, it will read to you what's on that screen. It will read to you what's on that paper. You can point it at a sign as well. They have a document reader. If you hold that phone up to a level at a certain 10 or 12 inches above a letter, it will take a picture and then recreate that with OCR. So you can two fingers swipe up on that screen or push the play button in the bottom left-hand corner, and your phone will read that document to you. There's a money reader there. There's a color identifier in there as well. I think we played with that earlier before we went to air. The barcode. You have a barcode reader. Scene recognition. You can actually take a picture and it will describe the scene. If you're in an office, if you're in a field, there are people playing on a field. All these great things, and it's free. You're dealing with a community that is usually dealing with financial difficulty. So anything you can do that's inclusive, less expensive, works well for the low vision community.
Mark had mentioned about cell phones, that cell phone's your best friend, and I've had patients tell me that this is my best friend with the technology. But speaking of best friends, I'd like to probably ask a question about best friends with a white cane. So about the benefits of a white cane for both of you who use one.
Jen, you want to take that first?
It completely restored my independence. It really did. Just, getting in and out of my house, going up and down the stairs every day, I don't have to hold on anymore. I can come and go a little freer. I can travel. I've been on several trips already, train trips, since I lost my vision, and it's all because of the white cane. It's getting me through. I'm going to Scotland in a couple of months, so it's opened doors for me too. I can live the life that I was used to living. So it's for me, it was complete restoration of my independence. So
yeah, same for me. It created the independence. It allows me to make it to work every day. I do not use paratransit. I use public transportation, so I'm mostly in the subway systems, or I'm dealing with buses and things, and the cane allows me to get to that bus stop or get to the subway. Sometimes I have to go see my students or clients in the field, so I'll go to their job sites and that, and it allows me to independently travel around New York City. I can go anywhere in New York City and get there. That last 50 feet may be some difficulty finding the front door, but just there are tricks and ways to do those things, and sometimes just asking somebody walking by, we'll get that done. So, but the cane was a major game changer for me. I wish I had picked it up sooner and not been so resistant to it. Once I did start using it, I know it sounds a little corny, but I actually nicknamed my first cane. That was my Sir Lancelot, because it was helping me slay my dragons and demons. So, and I was out there every day with it to go into Manhattan, because I knew that if I was going to re-enter the workforce in any capacity, I had to come off Long Island and go into Manhattan, because that was the best place for me to be able to do that, because where I live, it's a little rural, and public transportation is not as accessible, and I don't drive anymore, so that wasn't going to work for me.
So Ed, they're letting us know we're running out of time here,
Okay.
So do you want to wrap us up?
Yeah, let's wrap it up. I do want to thank each of you for coming today. I mean, you've lent some great experience and some great knowledge and insight into everything we've done. Thank you, Jen. Thank you, Dr. Dale. Thank you, Dr. Mark. This has been very informative, and not just for our audience, but for me as well, and I hope Jen feels the same way. So thank you. And everybody, it's been a great day, and have a great afternoon.
Yep, thanks to Rehab
Thanks
from
for
the
joining
Rehab
us.
Partnership.
Thank you.
For putting this on and for attending. So
Yes.
this is great.
Great, thank you.